thank you everyone for joining us for our BIMA clinical crash course series. For those of you who haven't joined us before, so we're doing this crash course. We started with Gen Med, we're now moving on to specialties, and we're starting with peds, as you can tell. Dr. Sharma, if you wouldn't mind going to the next slide. Thanks so much. So this is just an introduction to the team. Got President, Amar, Sarika's academic lead, and myself and Maharsh are the clinical officers. So we're the ones that are kind of behind the logistics of the crash course. So like I mentioned, this is our specialties crash course. So we're starting off with 5 weeks of peds, 4 weeks of obs and gynae, and then 3 of psych. So we hope to see you all for the next week's sessions, and it's every Sunday around this time. And just before I introduce this session, I just want to say right at the end of the slides, there'll be a feedback form. And if you could please fill that out. Dr. Sharma has kindly given up his time to teach us. So great to get feedback. And if you put your email address at the end, we'll email you a copy of the slides. So just to intro Dr. Sharma. So Dr. Sharma is an F1 at Barnet. I'll let him explain his interest in peds, but thank you so much. And please go ahead.
Thank you. Hello, everyone. I didn't actually expect this many people. I also didn't realize MRI was president, so it's fair play to him. Basically, I'm Shiv. I'm an F1 at Barnet. I hope you can all hear me all right properly as well. I have an interest in pediatrics since sort of the middle of medical school. I did my BSc in pediatrics. I've done a little taste week in pediatrics. And I hope to go on to do pediatric training after F2. If I could just let you know that you can sign on to menti.com and then put that code, and I'm sure the Imperial lot will be very familiar with that. And now after years of putting troll messages on Mentimeter, I'm now on the other side of that, so I'm kind of scared. But let's see how it goes. So there should be a couple of questions as we go through, and we'll be able to see how you guys get on. So you can just do that on your phone or your computer. Right, so let's get started then. So here's what I'm roughly hoping to cover today. Obviously, I know you will all have a focus on your exams, and I'll try and give you things that are useful for exams. And since there's a wide range of medical schools, I'm not going to be giving you, niche SBA knowledge that, generally is reserved for one medical school or another medical school, because that tends to vary and I don't want to waste your time. So I'm going to give you sort of two trains of thought. I'm going to give you things which every F1 should know, and I'm going to give you things which are very useful as a clinician as well. So things which, by the end of medical school, you should be grasping these concepts. And then also when you are assessing a child, what is actually clinically useful for those of you who, might need it. And you might think that, you're not going to do pediatrics, but actually if you have an A&E job, which almost all F2s will have an A&E job, you're going to be seeing pediatrics patients. If you're a GP, you're going to be seeing pediatrics patients. So actually the vast majority of you will be exposed to pediatrics patients at some point in your careers. So we'll look at the deteriorating child, which is slightly different to an adult, and we'll go through why and how to look out for things differently. We'll talk about assessing and managing deteriorating children. Fluid balance, I know, is a really tricky one, and I stressed about it a lot in 5th year. And I'll try and simplify that for you, because it's still quite tricky. DKA, anaphylaxis, seizures, these are kind of key emergencies to be able to manage. I'm not going to talk you through every detail of every guideline, because I don't think that's useful, and I'll explain why later. But you need to be able to grasp the basic concepts of management, the time scale of management, the order of prioritization as you manage these patients, especially in SBAs where you have 3 options, which are all good options, but one will be the most urgent for that particular emergency. And then we'll talk briefly about airway problems, which is something more prevalent in pediatrics than in adults, as far as exams go, especially. Right, so general principles of managing children. Arrests and emergencies in children, there's sort of a narrow range of common causes, and that is probably due to the fact that we're really good at preventative medicine in kids more than any other group. There are a narrow range of causes to know about, but they are just as important. And just because you won't get the spectrum doesn't mean you don't have to spend as much time sort of preparing and understanding them. And in fact, you're expected to know them in more depth than you would think, considering you're at medical school and you're not applying for pediatric training, especially especially that's what it was like at Imperial for sure, and I don't know what it's like everywhere else. It is hard to get clear history because you don't have a patient who's always verbal, and you don't have a patient who's always coherent enough and, you know, has the vocabulary to explain what's going on. You're not going to be asking, is it central crushing chest pain, or is it, you know, burning chest pain, and does it radiate to your back? Those things are much harder to ask in a pediatric population. It's hard to do invasive procedures and tests. You know, you're not going to be able to get bloods as easily. You're not going to be doing CT scans head to toe in pediatrics patients. So generally, you have to rely more on your clinical acumen and clinical signs and symptoms, which for some people is quite an attractive thought because, you know, there's less sort of fact-based and biochemical cutoff-based decision making. It's more clinical, and there is sort of more use of a clinician in those situations. Finally, you know, children compensate really well, and it took a long time to understand this until I saw some really sick kids in, you know, pediatric HDU and things like that on fifth-year placements. Kids can look fine, and they can be really unwell, and then when they drop off really quickly. So obviously in an exam, it's not going to be like that. They will telegraph it for you because you can't see the child on an exam paper, but you need to be able to understand that children will auto-regulate, and we'll explain some mechanisms later where they will actually hold up their numbers and look better than they actually are. And you need to be able to look for signs which are you know, harder to look for than an adult. An adult who's unwell will look it, right? But a younger child can look just fine even though they have, you know, fulminant sepsis. And that's why it's super important. These emergencies come about really quickly and they sneak up on you. And the other thing is that normal ranges for OBS change with age. I think that's really tricky. I don't think you should bother sitting there learning them all. I think it's not a good use of your time. Have a rough idea of what they should be. Have an idea of how they change. So for example, heart rate will go down with age, blood pressure comes up with age, rest rate goes down with age. And at 12 years old, you're expected to have like normal OBS as per the adult news chart. But with OBS, you need to have a rough appreciation for how they change, but I don't want you to learn the specifics because for your exams, you know, I'm expecting that you'll get the normal ranges. And if not, then they won't really expect you to be, you know, checking blood pressure ranges and knowing them for certain months and age groups as you go along. So here we go, assessment of the unwell child. So most of the principles are the same as in adults for initial assessment. You're going to go with your A to E approach as normal. So in A, it is more important in kids because kids have more difficult to manage airways because of their weight distribution. Their head is a heavier part of the body. You know, for example, in kids, they naturally sit in a more flexed position. So their airway does not need to be extended the same way as in an adult. So stridor and foreign bodies are a bigger part because kids swallow Lego pieces a lot more than adults do. And things like that become more important when you're thinking about emergencies. It's not just about medical emergencies, but about things that may have gone on around the child and them having external harm. Work of breathing is super important. And in adults, it's not quite as necessary because you have a lot more signs of someone being unwell, but you're looking at rate, you're looking at accessory muscles, you know, things like tracheal tug, subcostal and intercostal recessions. They're hugely important in pediatric population. That's what you're looking for to see how hard a child is looking to work. And those will often be the signs by which you decide on your clinical decisions, whether someone needs more oxygen or needs more nebulizers and so on. You're also going to be looking for things like air entry, wheeze, as per normal, cyanosis, and saturations. Saturations obviously is super important. As you know, based on your saturations curve, anything below 92, you do start to worry in many, many conditions, and it's no different in kids. Cyanosis, again, is a really late sign. So, you know, you have to be, I'm sure many of you will know this, but you have to be saturating 80 or so to start getting peripheral cyanosis. So peripheral cyanosis in this day and age is a lot less common. I've never seen it in my limited experience, but I would expect that if someone has peripheral cyanosis, it's a really worrying sign. Wheeze will be really, really, really common in children, that you'll be listening to their lungs and you will hear wheeze everywhere. The severity of the wheeze doesn't indicate the severity of the disease process, okay? Because it doesn't localize as well as we would think, that you listen in the right base and the wheeze means it's just in the right base. It could be all the way up the bronchial tree, and it could be in the bronchioles, the slightly larger airways as well. Air entry is super important when you're assessing for emergencies because you're looking for things like tension pneumothorax, which can also occur in kids as well as adults. I've grayed out a few things we use religiously in adults, which actually aren't as important in children. I mean, it can be argued, but it's something not to obsess over when you're doing a pediatric assessment or considering things in an SBA. Cap refill peripherally can be very varied in children. And because the autoregulation in children is so aggressive, their cap refill can actually, be abnormal even though the patient is well. Central cap refill is super important on the sternum, is much, much more important than on the fingers. And you can also have a warm sepsis. So you can also be peripherally perfused because your body is unable to, by many mechanisms that are probably way beyond the scope of this lecture, you can end up with a normal cap refill, but be severely dehydrated. So those things are all important. Heart rate, obviously critical. I mean, that's one of the, we'll talk about it later, how you stack up your signs of being unwell and being shocked. Pulse volume, again, is hard because kids have more tissue, right? We have a fairly prominent radial pulse. Unless you've got a morbidly obese patient, radial pulse is fairly close to the surface and good to feel. And in kids, it's just not there. So feeling the volume of the pulse is not going to be as sensitive a marker. You don't want to hang your hat on that. Heart sound, super useful for kids. If this were face-to-face at this point, I'd ask someone in the audience to give me an answer why. Heart sounds are super important in kids because you have congenital heart disease that can cause acute heart failure and decompensations. And if you have abnormal heart sounds, it can be very, very useful to pick those things up as well. Blood pressure, again, is not quite as useful because for two reasons. Cuffs on kids don't fit as well, okay? And secondly, that blood pressure ranges vary a lot, and they're generally quite low anyway in kids. So blood pressure of 85 systolic can be normal in a kid. So at that point, how low do you go before you say it's abnormal? It's tough to say. In SBAs, they will stick to hard, fast rules. So if your BP looks low on an SBA, don't say, they're probably fine. But in real life, if someone's blood pressure is a bit low and the kid looks well, you'll generally just say, it's probably a false reading. Let's get another reading and not panic about it. Femoral pulses, again, super important. Again, I would ask why, maybe have a think about why. Mucous membranes, useful again in a kid. Hard to tell if the kid is crying or unresponsive, to check mucous membranes. You can also ask mum what the feeding history has been like. That's also super important to knowing how a kid has been, because a kid will rarely drop off, but not feeding is a very, very sensitive marker of something being off in the child. It's one of those signs that I don't really know the explanation for why, but if a kid is not feeding well for a couple of days and then they come in desaturating, decompensated and unresponsive, it's usually a good marker of them having something that's been going on for some time, not just something that's happened this morning. Fontanelles as well. I mean, I don't know if any of you have ever felt a fontanelle. Really interesting how much you can put your finger into the skull of a baby. Slightly off-putting as well, to be honest. But you can feel that and feel if it's sunken. And that is actually a pretty decent sign, so I've been told, of dehydration. When I talked about femoral pulses are useful for coarctation of the aorta. So that can cause you to get an acute heart failure picture. And the femoral pulse is the best, most sensitive way of picking that up. So never ignore the femoral pulse when you're examining a child. So in terms of disability, sorry, I haven't put glucose on there. Glucose is super important. I must have just forgotten. AVPU is what we tend to use, and ACVAPU is actually what they use now, which is alert, confused, voice, pain, unresponsive. General rule of thumb is if someone is a P, and a child is only responsive to P, they're probably unable to maintain their own airway, and they need intubation or they need airway management. So they need anesthetics care. So the P is where you start to get concerned. Tone and posture is super useful. Again, you can generally see how well a child is by their tone. A floppy baby is never a well baby. Okay, it's just one of those clinical signs that is worth its weight in gold. Posture, again, looking for pain, looking for localization of symptoms. Again, kid will not tell you, but they can show you. GCS, I've grayed out because it's not as useful. It's definitely way, way harder to assess in a child. The value of GCS is diminishing, GCS 8, intubate, all that stuff. And I listened to a podcast recently. It's actually not that useful for determining outcomes anyway. And in a child, it's probably even less important because it's even harder to get a GCS reading. So don't sit there assessing the GCS for 10 minutes because it's part of your assessment. You just get on with managing what you see in front of you. And then E, abdomen, obviously you want to see if it's soft. There are abdominal causes of deterioration, bleeding, obvious causes of bleeding from trauma or PR bleeding or vomiting up blood. Those kind of things are super important. Burns, again, burns are common, well, more common than they should be in children. Accidental and non-accidental causes. They can cause severe dehydration very quickly. I haven't covered it in this lecture, but you can always look up the picture of how much of a child's surface area is, it's got a percentage breakdown of the palm of the hand, for example, it's 1%. And then, I think the front of the thigh is 8% on each side and so on. So you can actually work out the degree of the burn and therefore manage how much fluid you need, because they can lose a lot of fluid very quickly through the skin, and we'll cover why. Calves, not as useful in kids. You shouldn't really be getting DVTs unless you've got some kind of clotting disorder. But I've just put it as part of the assessment because why not? Okay. So what is the most common cause of arrest in pediatrics? If you go on your Mentimeter now, you can have a look and try and answer that question.
Dr. Sharma,
Yeah.
we've got a question in the chat. Someone's asked, with reference to femoral pulse, what age do you go up to before you wouldn't check this?
Interesting question. Technically, you should always check it in everyone. We don't really do it in adults. It's just one of those things that people are like, oh, it's such an obscure cause, they don't really bother doing it as part of the examination. I couldn't tell you, to be honest. I couldn't give you a definitive age. Well, good question. I think you probably have to just judge it. Yeah, I'm sure there's a good textbook answer for like what age coarctation will present, because you can have adult type coarctation in teenagers, and it does happen. So definitely check up to 6 months, a year, 2 years, maybe even 5 years. Beyond that, it's probably up. It's beyond my knowledge. It's probably the safest answer for me to give you. Shouldn't be afraid to say I don't know, but definitely check it in your young population up to 5, 6 years of age, because you never know what congenital heart disease may have been missed. If you're the first person to examine that patient's femorals, they may have gone 8 to 10 years with the coarctation that's just becoming symptomatic now because the child is growing or becoming more active. Sorry, I can answer your question properly, but I hope that gives you a rough idea. There's very few hard and fast things we do in medicine, as I learn more and more, to be honest. Right, so I'll just show you guys the answer. So most of you are bang on. So hypoxia is the most common cause of arrest in children, and we'll talk about why all that is later on. Here is your pediatric life support algorithm. Okay, I don't want you to focus on the details. Okay, please don't focus on the details. There's a general rule. You're going to go and assess the patient briefly. So you just want to do a quick ABC assessment. You feel a pulse, check if they're breathing, put out a crash alert. You should all know it's 2222 on the wall, or just shout for someone. All those things will work, or pull the alarm bell. You want to attach a defibrillator. You want to start compressions immediately. Okay. You've got the same, causes of arrest as you do in adults. Okay, the same spectrum of causes apply here. Your 4H's and your 4T's. Hypoxia is a more common cause in the pediatric population because children tend to have more airway problems. In children, the airways are less developed, and the difference in adults is that in children, the heart is always, is acting well below capacity when you're born. But when you're born, your lungs have to inflate. That whole system has never been tested before and has to inflate, and all sorts of changes at a mechanical level and a biochemical level and a systemic level have to be undergone in the lungs. So hypoxic causes of arrest are the vast majority. I think it's up to 80% of arrests are due to respiratory causes. There's two things that changes in our management compared to adults. You'll note that we do two things differently. We do 5 inflation breaths, okay? 5 initial breaths with mouth to mouth or with a bag valve mask, okay? These help to inflate the lungs in case there is a respiratory cause, and we can get the patient back before even needing to start compressions, okay? If that doesn't work, we do compressions, but in a 15 compressions to 2 breaths ratio. So basically we double the number of breaths compared to an adult. And again, that is to reflect the volume of respiratory arrests compared to cardiovascular arrests in pediatric population. Don't ask me if that's evidence-based. I can't imagine anyone has done an RCT. I'm sure that's just a best guess of what kind of ratio we should be doing compressions in. But it's based on theory and probably a bit of evidence combined to come up with that. So if you're going to know anything about pediatric resuscitation, know that it's the inflation breaths and the ratio of compressions to actual, inflation to ventilation breaths that is the difference. And just be aware of those. It's 5 initial breaths and it's 15 to 2. If you learn nothing more from this slide, just take that away. The rest is sort of ILSE. I wouldn't worry too much about that. You will get that, later on with rhythms. I'm not going to concentrate on that now because it's not any different to adults. But kids can also have arrhythmias, and oftentimes because of the anatomy of their congenital heart disease, they can present with arrhythmias before they present with the valvular disease from tetralogy of Fallot and things like that. During CPR, you're doing the same rough things. You're getting vascular access, you're getting fluids running. You give adrenaline every 3 to 5 minutes. You need an anesthetist because you'll need an airway. You'll need a definitive airway in an unresponsive patient. You need to consider your reversible causes. Okay, so you're going to have fluids running. You're going to get an ABG so you can check their potassium and their lactate and things like that. You might want to get a fast scan, which is a bedside ultrasound to see if there's cardiac tamponade. You're going to look at the trachea and listen to the breath sounds to see if there's any tension pneumothorax. Thromboembolism is a very rare cause of pediatric arrest, but you're still going to be part of it. You get a warming blanket and you check the temperature of a child to make sure they're not hypoxic. Hypothermic, okay, which again can happen in neglect or children who, fall into rivers or go swimming and get, these things happen more in children than in adults. So it's something to be wary of. Toxins, again, are super important because kids will take things that aren't, they don't overdose on heroin or cocaine or whatever. They will take their grandma's diazepam or amitriptyline or things like that. And these can lead to nasty situations where you have arrhythmias or you have, drowsiness and need them to maintain their own airway. And those things can happen as a result of toxins as well. So just be wary of that. It can be snuck into an SBA. Usually if they put it in SBA, it's pretty obvious. But in real life, it really can go very subtly, especially when you've got family members who aren't sure what's going on and are panicking and you can't get a good collateral history, or they don't speak English, and all these things happen on a regular basis. Right. So what is shock? Shock is, inadequate circulation to meet the metabolic demands of tissues. I'm sure you've seen this probably twice a year for every year of med school now. So this will make it number 11, which will be quite tiring, but someone's drawn on my slide. Thank you. The reason children are more likely to develop shock, they're more prone to developing shocks. They have a higher surface area to volume ratio, okay? Reading an interesting book about sort of evolution and how things grow. And it just shows that smaller animals have to have a high metabolic rate because of how their surface area to volume ratio varies. And because these children are more likely to lose fluid, they need to maintain a more dynamic circulation. They have to have a higher heart rate. They will maintain a lower blood pressure because of perfusing all those peripheral tissues that lose fluid. They lose fluid faster from skin. That's why burns are way more important in children. And they've got a high energy demand because they are growing at the same time as maintaining, which we just will not be doing as adults to the same degree. Okay, so they are more prone to being shocked. Things can shock them easier. Now, on the flip side of that, we've got children compensating really well. Their autoregulation will shut off peripheral circulation quickly to maintain, organ perfusion rapidly. They will divert blood away from the bowel, which we'll cover more in the neonatal lecture in a couple of weeks. And so your signs can be late and they can come on really, really quickly, okay? So let's see what signs we should look out for early. Why do they become shocked? So I've put sort of just a few main causes up here. So congenital factors, this is so interesting in pediatrics, is that people will be born with stuff that will cause them to then go on and develop shock, okay? So like we said, congenital heart disease, lung hypoplasias, which is, don't worry about that. That's all beyond the scope of sort of medical school. And bowel problems, volvulus, intussusception, perforation, necrotizing enterocolitis, all these things can cause you to become shocked and are to do with congenital factors. Trauma, again, trauma exists in children just the way it does in adults, if not more. Sepsis, just as it does in adults. Anaphylaxis, probably more common in children, and we'll cover that later. And metabolic disorders, so diabetic ketoacidosis or inborn errors of metabolism, can lead to children becoming very unwell very quickly with no sort of latent phase. Now, the next question on Mentimeter, which of these is a late sign of shock? How do I... Slide. Oh, someone's asked, how common is cardiac tamponade in children? Tough to say, not common, not common. So I wouldn't worry about it. So I've opened the next question, I think, on Mentimeter, so you can go and have a look at the next question. So answer, which of the following is a late sign of shock? So we've got 100 responses. Okay, so the correct answer is what about a third of you gave. Okay, and it is hypotension. So well done to the 37 of you who thought that. Interesting two-horse race between decreased urine output and hypotension. We'll go to the next slide. So hypotension is a late sign, okay, of shock. In adults, it can become an earlier sign, but even in adults, it's a fairly late sign. Because if you think about it from a physiological perspective, your body will do everything to maintain perfusion. Fundamentally, it aims to maintain perfusion to the brain, the heart, the kidneys, and the lungs, okay? It's evolved to do that. There are so many mechanisms, so many inefficient mechanisms to do that, that it will do everything to preserve blood pressure, because without blood pressure, nothing can work and you will die. So, you know, it's a positive feedback mechanism. The first thing your body will do is you'll become tachycardic. Okay, your heart rate responds quickest to a drop in blood pressure because the lack of stretch, you know, lack of preload, according to Frank Starling curve. So the blood pressure will increase. You will then get peripheral vasoconstriction. That's more as a result of hormones, okay, your adrenaline and noradrenaline that get released. So your cap refill time and your cold skin will happen. Okay, if you go outside, you know, I went out for a bike ride today. Big regrets, to be honest, because I couldn't feel anything when I got home and I almost skidded into a bus. But your fingers will get cold just from going outside, but your body will maintain warmth and blood pressure to your central system pretty well, even in the coldest, nastiest conditions. So when you're shocked, you will develop that, but you'll develop that really early. And so it is a reasonable sign to look for. The cold skin, the cap refill time that we talked about, cap refill time is tough. Some people will naturally have a long cap refill time, but if it is going to be a sign of shock, it's an early sign. Decreased urine output is interesting. Your urine output will decrease remarkably early in shock. Okay, so a baby who hasn't wetted its nappy is a worrying sign. So not feeding and not wetting your nappies are two worrying signs. And even in adults, decreased urine output, you know, you walk in, you see an empty catheter bag in a patient who's got an infection and you worry. So it is an early sign. Hypotension is the last thing to go. So that's why the takeaway from that question really is that I don't want you to look at a question and see the blood pressure being high and assume that means wellness. Like we said constantly, the theme of this whole talk so far has been that kids will compensate well. And the blood pressure will be the last thing to go. By the time the blood pressure goes, you've already got a lot of things to worry about, okay? So here's a list. I've taken this straight out of LaSalle's textbook, shamelessly. I think it's a really good list. And, you know, short of Googling septic babies, this is how I build a picture in my head of what I'm looking for in a really sick child, a sick child on the left, for example, and a seriously sick child on the right, okay? I mean, the difference between decreased urine output and absent urine output is a tricky one. I don't think that's the real distinction you can actually make, because you don't know how much they're taking in, to be honest. And you don't know what other factors they have. You know, if they have burns, they have more fluid loss. If they're a smaller baby, they have more natural fluid loss. So it is tough to say, like, you know, decreased versus absent urine output. But the rest of it holds very true. Okay, and what are we going to do about it? Well, pediatric resuscitation fluids, 20 ml per kilogram bolus of blood if they're bleeding, okay? Because if you're bleeding, or crystalloid, okay? And you can do that twice over. So you can give them 20 ml per kilogram boluses, and you can run that through at the maximum rate, okay? So whatever, you can do a liter of fluid and, you know, at the a liter an hour kind of rate, or maybe even faster than that, depending on if you have pressure bags. You can do two times before you need to consider ITU support. So if in your SBA, you've got a patient, you know, who's septic, who's come in, they've had 2 boluses, and it asks what the next best step is. The next best step is to put out a peri-arrest call, because if someone's not responding to fluids, it's going somewhere, and that's a really worrying sign. It either means you're very vasodilated and you cannot maintain your peripheral circulation, or it means you have a source of bleeding. If someone is bleeding, you do not want to give crystalloids. When I say crystalloids, something like Hartmann's. Hartmann's is a really good resuscitation fluid. You don't want to give sodium chloride. I know it's common in med school to give everyone sodium chloride. Sodium chloride has too much chloride in it, okay? And the chloride will cause efferent arterial constriction in the kidneys and cause renal failure later down the line. So you'll resuscitate someone and then their kidneys will start packing up 2 days later. So you don't want it because of the volume of chloride. You want to give Hartmann's because Hartmann's is physiological fluid, right? It won't increase or decrease your electrolytes, but it also doesn't have the chloride volume that will cause damage to kidneys. if someone is bleeding, you want to give them blood. Okay, blood products are the best to give to anyone who's bleeding. If you give someone, this is very important because it's only come out in the last 5 to 7 years, really. In a trauma situation, if someone's bleeding and you give them anything other than blood, you essentially dilute their clotting factors and platelets. And if you dilute that, you're never going to plug the source of bleeding, which is the source of loss in the first place. Okay, so actually, it's better to just give someone blood if you can, because that will maintain, and you can give them cryoprecipitate and FFP to maintain the clotting factors and the ratio in the blood so that they're able to achieve hemostasis. If you give them fluid and you make them unable to naturally achieve hemostasis, you're in big trouble, because after that point, they're not going to stop bleeding and you need to keep pouring fluids in, and it's a never-ending cycle. Okay, that's all fairly clear. So fluid balance is more complicated in children. Adults, nice and simple, 30 mils per kilogram per day, and you give them a bit of sweet stuff and a bit of salty stuff. In children, so like we said, there's two stages of fluids. So resuscitation fluids, the child is acutely unwell, 20 mils per kilogram twice as needed, all right? Maintenance fluid is done by body weight and stratified by ranges of body weight. And this is done because of the surface area to volume ratio. So for example, a 10 kilogram child will need more fluid per kilogram than a 20 kilogram child or a 50 kilogram child, okay? And that's quite tough, and they stack on top of each other. So we'll talk it through, okay? So the next, I'm gonna show you next. So if you've got a 23 kilogram child, how much fluid do they need as maintenance over 24 hours? Okay, so that's 23 kilograms. I'll go back to show you the ratios. Okay, so I don't know if many of you have got it. I know I really didn't like this concept, and I just found it a bit weird, having not done maths for a few years. Let's talk it through, okay? So your first 10 kilograms are gonna be 100 mils per kilogram. Then the next 10 will be at 50, and every kilogram after that is 20 mils per kilogram, okay? So I've broken it down into a nice little table here. So you're going to give 100 mils per kilogram for the first 10, that's a liter. Then the next 10, you're going to give 50, so it's 500. So it's 50 times 10 for the next 10, which is 500. And now for every kilo above 20, they need 20 per kilogram. So this child is 3 kilos over 20. So they need 3 times 20, which is 60 mils on top. And that gives you their 24-hour maintenance fluids, okay? You can divide that by 24. I like to put it this way. I think when you actually prescribe them, I've been told that they prescribe them hourly rather than 24 hourly. But this, I find, is the simplest way to calculate it. You can go up or down from here. It doesn't really matter. And it gives you a good idea of what's going on, okay? I know it's tricky. Would anyone like me to repeat any of that? You can just write something in the chat quickly, because I do understand it's tricky. Right, so we've written here, okay, in fluid balance, right, the bigger your child, the less fluid you give per kilogram, essentially, okay? So if you've got a 10 kilogram child, you're giving them a liter of fluid. But if you've got a 20 kilogram child, you're giving them 1,500 mils of fluid, okay? So it's less per kilogram because the surface area to volume ratio and the reasons we've talked about so far. So up to 20, so first 10 and the next 10, you need to keep adding them on. So they are cumulative, okay? The fluid balance is cumulative. And so if you look here, right, we've done it, we've broken the child's weight, the 23 kilos, into 10 kilos of the first 10, 10 kilos of the second 10, and then what's left, the 3 kilos above that, okay? No, good point, RJ. I did forget to mention this. So maintenance fluids in peds are different, and they will usually give saline with dextrose. I think they call it dextrose saline or something like that. And you will combine, it's a fluid that's combined the two, because I can't remember actually. I'm not sure it's the ratio. It's the ratio of what children need is just different, I think, because of the metabolic rate. They just need more of, they need a constant supply of dextrose. I think that's the theory behind it, at least. It does vary. I don't think you're expected to know exactly what kinds of fluids are needed in pediatrics. Just know that it's the 0.9% saline with 5% dextrose is one of the common ones that they use. If you've got resuscitation, it's Hartmann's. If you've got maintenance, it's usually dextrose and saline combined. It used to be really popular in adults until people started messing with sodiums, and from then on, now we just use separate bags. Yeah, that's it. That's exactly it. So you use 0.5% sodium chloride and dex, or 0.9% sodium chloride and dex, and that's what they usually like using. Okay. Do you have to add potassium to the bags? It's a good point. I think you would usually give sort of 20 mils per liter, 20 millimoles of liter per liter, 20 millimoles of potassium per liter of fluid. And that is a good consideration. But of course, you're going to see how the child is. For example, if they've got vomiting, you're going to give them more potassium, okay, because you're going to have GI losses, for example. If your patient comes in and they've had hyperkalemia, you're going to give no potassium. And if someone's got DKA, then you're going to give even more potassium, as we'll cover later on. Yeah, so Zana, that's pretty much it. 0.45 or 0.9. It varies depending on what they're trying to achieve, plus 5% dextrose. That's a complicated question, and it's not the same for every child. So I think it would be very unfair for them to ask you that in an exam question. All I want you to be able to do is to roughly calculate, because being able to calculate the fluid requirement is a very common question. So as long as you can nail that, it doesn't matter after that what the actual fluid is, because different situations will need different fluids, and it's probably beyond the scope of med school to understand what pediatric fluids are used in what situations. Okay, I hope that's all right. So here's a rough sort of breakdown of shock, and again, it's from the illustrated textbook of pediatrics by Lissauer, and it shows you sort of the types of shock. So you've got hypovolemic shock, as we've covered a couple of causes there. You've got maldistribution, which we'll see later. Cardiogenic shocks, that's a failure of cardiac output. Okay, this is different to hypovolemia. And neurogenic shock we're not going to cover today, but as you know, neurogenic shock you don't have the ability to respond to low blood pressure. So there's no tachycardia, there's no peripheral vasoconstriction, you lose those responses, and as a result, you become shocked disproportionately to what your clinical exam is. All right, I quite like that because it puts it in a nice, straightforward picture for you. And you note how sepsis does two things. It does hypovolemia, you become dehydrated, and it also maldistributes your fluid. So you get a cumulative effect from sepsis. So here's sepsis, right? And I remember this diagram well. I know it's an American diagram. I remember in second year, getting my head down, scribbling away, copying it down. Oh my God, there's colors and there's bars that go up and there's underlining and there's pluses and there's numbers. Oh, this is so useful, right? And then it's only recently that I thought about it, because I was thinking about models of sepsis and I forgot that we'd seen this and someone brought it up at some point. This is not used anymore, okay? And this is what I would call the BIMA model of sepsis, all right? It doesn't actually help you. When you see a patient, you do not see their white cell count. You do not see their PCO2. You do not see signs of end organ damage, okay? You do not see if it's persistent or not, all right? You can't grade a patient on this spectrum easily at all, right? So it's actually not that useful. This doesn't turn into seeing a patient, right? So this is not used, as far as I'm aware, by anyone really at all, and especially not in pediatrics. And we'll show you the pediatric system later. I'm sure you're familiar with it. We'll talk about the pathophysiology of septic shock, okay? Because this is obviously very biochemical, and I understand that you do like biochemistry and pathology. So we will talk about it briefly. So you've got, number one, increased vascular permeability, okay? So by virtue of the inflammatory cells that are your white cells that are roaming around, so TNF alpha, all these cytokines, you're going to get capillary leak. And as you leak, that allows the white cells to tackle a source of infection. If you had, for example, a cellulitis or a necrotizing fasciitis or, intra-abdominal infection, it would allow you to deal with that because you've got more infective cells there. You've got more, white cells there. But it doesn't actually help you in terms of your blood pressure. And if it goes too far or it's too persistent infection, it can lead to decompensation. You've got reduced venous return, okay, reduced preload on the heart. So it does get worse, okay? So this has a knock-on effect that, at the capillary level has a knock-on effect at the level of the heart and the systemic circulation. Number two, you've got vasoconstriction to maintain critical organ perfusion, all right? I think we all know that. We've talked about it enough, so I'm not going to keep banging on about it. Intravascular thrombosis. This is super interesting as well, okay? You get the inflammatory response causes platelet aggregation, and you get maladaptive clotting. Someone's drawing again. Thank you. You get widespread purpura, hemorrhagic necrosis, even gangrene in end-stage sepsis, okay? These are things you don't really associate with sepsis, because why would an infective process cause you to start clotting, right? But it does happen, okay? And it's a fulminant sign of disease. It's an end-stage sign of disease. So it is something to be very, very worried about if you get to that stage. Myocardial dysfunction, you actually get myocardial dysfunction as well. The interleukins and cytokines, magnesium, potassium, and calcium abnormalities that you develop from renal failure and from capillary leak end up giving you electrolyte abnormalities that cause arrhythmias. But this usually resolves with sepsis. So you can see how everything kind of becomes additive. As soon as one thing goes down, the next thing goes down, the next thing goes down. It just gets worse and worse. And then finally, yes, for the SIRS fans, you do get systemic inflammation, right? So the cytokine storm, reactive oxygen species, endothelial leak, all this stuff contributes in a massive way. Here's what we use in pediatrics, okay? And this is a really clear system. And note the difference between this and the previous bar charts that we had, okay? This is much more useful for you clinically to actually see what is happening to a patient because it stratifies symptoms. Everything here is a symptom, is a history finding, is a sign on examination, okay? Nothing here is wasted. Nothing here needs time. Everything is very clear in front of you. And you should have an idea before your exams of a child. You can just be able to picture a child in each category of the traffic light system, okay? So obviously, naturally, red is the most worrying sign. The other thing to note is the importance of the parents in this. Parents are a part of this, right? So pallor reported by parents, poor feeding reported by parents. These things are all a factor that you can actually use clinically rather than asking. You can't ask a parent, oh, what was your child's last lac date? It doesn't actually, what is that, right? Important to note the clinical signs here, right? So red signs to note for, we'll just go through them quickly. Appearing ill to a healthcare professional, right? That just isn't a thing in adults. In adults, that's not a criteria of sepsis, but in kids it is, okay? Because your end of betagram and your clinical judgment is super important. And that's why it's harder in a pediatric SBA to assess, how good you are at judging an unwell child. The most important thing to note there probably is things like an age less than 3 months with a temperature more than 38 degrees. Okay, that's been shown to be a sign of someone deteriorating quickly, and that's a sign of decompensation quickly. Non-blanching rash, bulging fontanelle. Okay, bulging fontanelle, sign of raised ICP, very worrying sign. Neck stiffness, status epilepticus, those things are all super worrying. Okay, how do we deal with this? Okay, we will manage by starting blood cultures, urine MCNS. Okay, in these septic childs, you will always do blood cultures. If someone is febrile, you do blood cultures. If someone's not febrile, the blood cultures aren't actually that useful. LP, so you can do an LP if they are under 1 month. You must do an LP, okay, because the risk of meningitis or meningoencephalitis, and you consider if they're very sick under 3 months. Okay, so just have that idea as your basic management of a child. You're going to do some investigations. You're going to do blood cultures before treatment, ideally, because you don't want to have any antibiotic in the blood cultures, but it shouldn't delay your management. Next, you're going to do your fluids. So if they're shocked, you're going to give your 20 ml per kilogram bolus of fluids, as we've discussed before, okay, up to 2. And then, I don't know why it's not, okay. And then your antibiotics. So it's very different to in adults. You're going to give a 3rd-gen cephalosporin because in kids, gram-negative organisms can be nasty very quick and are more prevalent. All right, gram-negative sepsis is more common and worrying in a child, so it's what you want to cover for. So you're going to use a ceftriaxone or a cefotaxime, something like that. You can add amoxicillin if under 1 month. I'm sure some of you will know why. Okay, and that's because of the risk of listeria. So listeria is a more common organism in younger children. So you're going to want to add amoxicillin to cover that because your cephalosporin isn't going to give you that cover as well. And then finally, if someone is really sick, you're going to add gentamicin. Gentamicin is a pretty nasty drug. I remember at Imperial, we weren't really taught much about it other than that it trashes your kidneys and your ears and horrible stuff. But we use loads and loads of it at Barnet. And I was like, why? But once you've seen someone with sepsis with one dose of gentamicin, you see how much they improve. It's actually kind of crazy how effective it is as an antibiotic. Right, what's causing this? So this is, these are sort of red spots at the top of the skin. Okay, I'm sure, I hope is someone written right in the chat? No, but this is caused by meningococcal septicemia. Don't see it much anymore, but it is really dangerous and absolutely lethal. Okay, and it can cause life-changing, sequelae as well afterwards. You know, you will get seizures, you will get mental retardation, you'll get limb loss and gangrene and fulminant organ failure as a result of meningococcal septicemia. So it's so important to treat the quicker, you know, someone comes along. You give an IM dose of benzyl penicillin if someone is at home or in the GP setting. And if you're in a hospital, you start ceftriaxone or cefotaxime as you would with the previous system, okay? And what you're seeing here is a non-blanching purpuric rash. And this is a sign of the intravascular thrombosis, which is quite unique to meningococcal septicemia. It's more of a sign in meningococcal septicemia than any other cause of bacterial sepsis. So it's something to look out for. And you ask parents to do the glass test. So you just ask them to get a glass and you ask them to press on it. And if it doesn't blanch, then it's a worrying sign, okay? Right, so let's move on to anaphylaxis, all right? If you had any questions about sepsis or anything that we've talked about, please put it on the Mentimeter and we can talk about it at the end. So anaphylaxis is a systemic allergic reaction. You've got cardiovascular involvement, you've got respiratory involvement, okay? So these are this is one of the critical time-sensitive things to know about. And I'm surprised by how badly, you know, people don't really know too much about anaphylaxis, or didn't, especially 20 years ago, which seems like a crazy short amount of time ago, right? But people used to die a lot of anaphylaxis, and now it's a lot better. Type 1 hypersensitivity by that classical system, it's kind of antiquated, but it's okay. Surprisingly, when I was reading about the pathology, there's actually not a lot of knowledge about one common pathway that unifies all the factors, and a lot of patients will react in different ways from different things and at different time scales and different severities, and no one knows exactly what is causing it in each patient, okay? Antihistamines don't work to prevent anaphylaxis, and it doesn't help a lot of people with their symptoms, so it's probably not all histamine driven like we might think. Common triggers: food products, so nuts are the main one, then dairy products, sort of tree and animal products are the main ones. Medications, contrast can be nasty. And medications, you're thinking things like penicillin allergy is probably one of the most important things to know about, okay? Uncommon presentations. So again, we kind of will talk about the typical presentation, but you need to be aware that people's blood pressure, you know, 20% of people's blood pressure will be normal with anaphylaxis, okay, which is kind of scary, because someone could be in anaphylaxis and you'd be like, no, but the blood pressure is okay. So maybe it's not, right? Diarrhea and or vomiting, again, very strange signs. Like if someone's vomiting, you wouldn't walk in and immediately think it's anaphylaxis. So it's something to be aware of. Common presenting signs. So here's our ABC management of someone with anaphylaxis, a textbook case, right? Throat, tongue swelling. You feel like your throat is closing up. They'll often tell you, I can't breathe, okay? Or, you know, I'm struggling to swallow. It feels like my throat is sticking together. And I looked at that and I thought, okay, but then actually we had someone with anaphylaxis and they said exactly those words, my throat's closing up, in A&E last month. I thought it was kind of funny coincidence. Gasping and stridor. Stridor is a really good sign of airway interference. A hoarse voice, again, that'll be a very mild anaphylaxis. Shortness of breath, tachypnea, wheeze, exhaustion. Exhaustion is a bad sign. Exhaustion is, you know, a late sign. So if someone is starting to not breathe at a high, you know, not have a high respiratory rate, or their PCO2 is starting to become normal, right, then that's a really worrying sign. Circulation, someone will typically become peripherally shut down, because your body should go into full-on, not peripherally shut down, they should become peripherally vasodilated. They might get a rash. They will sort of dump all their fluid in interstitial tissue. So they can become edematous, although that usually takes time. But the main thing to look out for is tachycardia and hypotension from a circulation perspective. And then the skin and mucosal changes, 80% will have erythema or an itchy rash or angioedema. And you can sometimes see it in the mouth and lips, especially. You know, lips are the most common places to look at if someone's having anaphylaxis. Right, so you think it's anaphylaxis, doctor, shall we wait for the bloods to come back to make sure? Does anyone know what blood tests we can use for anaphylaxis? Yeah, so yes, exactly. So mast cell tryptase is actually a very useful thing to use for anaphylaxis, because in cases where it's a bit indeterminate, you're not sure if it's anaphylaxis or not, it can be useful. However, it shouldn't delay management. It should be done at 1 to 2 hours post-symptom onset, okay? So it's not something you're not going to be like, I think it's anaphylaxis, maybe I'll send off a mast cell tryptase, okay? You're going to jump straight in, because you can't afford to wait, right? So this is taken from the Resus Council, and it shows you the time to cardiac arrest for different reactants and and how many deaths they cause. So you can see here that food kills a lot of people, okay? But so do medications, right? Things we do. So we'll give people penicillins and it will kill them. And penicillin kills quick, right? Penicillin kills real quick here, as you can see, especially IV penicillin. So if someone starts to look anaphylactoid, okay, you need to move quickly, all right? I think that's the main takeaway from this slide, really, is that you need to understand that injected medications like penicillins and contrast are the most worrying things. They're the ones you should be on high alert for anaphylactic reactions. And secondly, you can't delay your management because a lot of people will be dead after an hour, not even an hour. Right, so here's the Resus Council algorithm. So you're going to do a quick examination, right? You're not going to be there doing AVPU and checking someone's carbs. If you think it's anaphylaxis, you should jump straight to adrenaline, okay? This algorithm has been criticized a lot because adrenaline is a very small box and it's quite low down. Adrenaline should be your mainstay of treatment, okay? Adrenaline, you want to give in these doses. So have a rough idea of, and there's not many dosings I'm going to expect you to remember, but you should expect this, okay? You should learn this. Under 6, 150, 6 to 12, 300, above 12, adult dose, okay? That's probably the best way to remember it. And it's all given IM. And you give it into the lateral side of the thigh, the anterolateral aspect of the thigh. You can give 2 or 3 adrenalines, okay? After a few minutes of no response, 5 minutes of no response, usually. Key point to remember clinically, not for an SBA so much, make sure you don't give it into the same thigh twice, because if you give it into a thigh, it will cause vasoconstriction in that thigh, which is what you want. If you inject the second dose because the patient is not responding into the same thigh, you won't get the uptake into the bloodstream that you want, and you won't have any clinical response to that second dose, okay? So make sure you give it in the other thigh. And you can also give it up here in the deltoid as well if you need to give doses 3 and 4, for example, and you've got a skinny patient, all right? So the main points here, raise your patient's legs, call for help, raise your patient's legs, and adrenaline, adrenaline, adrenaline. It's the most important thing. You need to give them oxygen. You need to give them fluid bolus, like we said, 20 milligrams per kilogram. But you need to get adrenaline because ultimately, what's the cause? It's all the vasodilation. You need to restore their circulation centrally, okay? After this is all done, you're going to give a couple of things. So chlorphenamine is good symptomatically. So 10 milligrams of chlorphenamine, for example, I think probably less in a child. It's quite handy for symptoms, so the rash and the irritation that people will have and maybe the GI symptoms. But the hydrocortisone is not used for treatment of anaphylaxis. People can often, a day down the line or 2 days down the line, have a rebound anaphylaxis, okay? They can have a rebound anaphylactic reaction after an initial treated episode. So you discharge the patient on 2 days, you teach them all about their EpiPen, and then 6 hours later, they're brought back into hospital, they're having another anaphylaxis reaction, okay? Hydrocortisone is useful because it doesn't work straight away. It takes 6 to 12 hours to work. But once you get it in, it will help to stop any residual substrate for anaphylactic reactions and stop you getting that rebound anaphylaxis a couple of days down the line. All right? So again, from this, I don't want you to copy much down. Just note, call for help, raise patient's legs, adrenaline, maybe oxygen fluids, and then the doses of adrenaline. And if you really want the style points, you can talk about chlorphenamine and hydrocortisone, but they're not the be all and end all of management. Right, so diabetic ketoacidosis, all right? So DKA is life-threatening, all right? But a lot fewer people die. I think the rate of dying from DKA was sort of 8% in the 1980s, which is quite a lot when you consider that it's very treatable and it's a very young population, right? But nowadays it's less than 1%, so that's really good. It can often be a first presentation in an undiagnosed child. Usually it's not your young children, it's usually 6, 8, 12, 15 years old. In an SBA, they will have family, their mum has a thyroid problem, or grandma had rheumatoid arthritis, or someone else had a type 1 diabetes. So you're going to get those little clues in SBAs as well. There's sort of 2 phases to a DKA. You're going to have a latent phase. You're very rarely going to go straight into DKA. Okay, you're going to have a sort of grumbling type 1 diabetes picture, polyuria, polydipsia, weight loss. The ketoacidosis comes on acutely and is life-threatening and can be triggered by sepsis, commonly sepsis, okay? And as a result, you're going to get dehydration, fluctuating consciousness, abdo pain, vomiting, and you're going to get a sort of ketone-y, acetone-y smell on the breath, okay, which is not usually an SBA point, but it's something to bear in mind. Here's the rough pathology of how it works. It's a really good diagram. It's better than I could ever explain it, okay? You essentially end up in a state where you get increased lipolysis and you get increased ketosis because your body doesn't have the natural mechanisms to use glucose, all right? And you're going to end up with this triad here of clinical symptoms, or clinical and biochemical symptoms, hyperglycemia, acidosis, and ketone, high ketones, all right? So principles of management. So as before, you got a fluid bolus if they're shocked. This is slightly different to in adults, but you're going to keep roughly the same thought process, the 20 mils per kilogram, and then 2 more 10 mil per kilogram boluses if needed before you call ITU. You're a bit more delicate with fluids and DKA, and we'll talk about why later on. Insulin infusion, you start it 1 to 2 hours after starting fluids, right? Now, why is that? Why? Surely insulin is the mainstay of treatment in DKA. And the point of that is twofold, right? The fluid you give will naturally lower the glucose. These patients do not suddenly develop high glucose. They have had it for weeks, days, if not weeks. And so you're going to have patients who are hyperosmotic. Someone muted me. Have you guys had enough? So you've had, I don't know what you heard there. So the patients are going to be hyperglycemic and hyperosmolar for a long time. If you give the act of giving them fluids will reduce their blood sugar, okay? You don't want to give too much insulin because you don't want to risk dropping the blood sugar too quickly and changing the osmolality too quickly and potentially put them into a hypo amongst other things, right? So it's not something you want to treat super quick. Anaphylaxis, like we said, was like straight up, adrenaline in either hand, bam, bam, really quick response. DKA, you have to be delicate. If you rush DKA management, it can be really, really messy, okay? And there's often very complicated algorithms to make sure people don't manage it too fast, in too much haste. The role of insulin is to stop ketosis. It's not to reduce the glucose. You can reduce glucose effectively with just fluid. The role of the insulin infusion is mainly to stop ketosis. And once you get to that stage, you can stop the insulin. We'll talk about that in a minute. If a patient is already on like a known type 1 diabetic, you keep their regular basal long-acting insulin going. You stop the short-term insulins in the meantime while you manage their DKA, all right? If their GCS or AVPU reduces, you need to do an NG tube because they're going to be vomiting and you might risk an aspiration, which can be pretty nasty. And it's not an issue you need. You might as well try and, make life easier for yourself. So the fluids, you're going to give potassium and dextrose in the fluids because you want to slow the glucose. You want to make sure the glucose falls at a slow, steady, controllable rate. Fluid management is really complicated in terms of maintenance fluids in DKA. I don't expect you to understand it fully. Just have a rough appreciation that there's 2 arms of fluids. You're going to give maintenance fluids, and there's a fluid deficit to correct. If someone is in DKA, as in the acidotic, to a certain level, they will have a fluid deficit, and you need to correct it really slow. So you give maintenance fluids as if you would any normal person who's not eating and drinking, and then you give a deficit, you've got a deficit to correct, and you correct that over a period of 48 hours. So you use sodium chloride and 40 millimoles of potassium per liter, because as you know, insulin will cause you to drop your potassium, okay? So giving someone an insulin infusion will cause them to drop their potassium, and you want to make sure you maintain the serum potassium, or you're going to get arrhythmias, and that can be another issue you don't want to cause, okay? And the final issue is regular monitoring. So you're going to be doing sort of hourly glucoses and ketones via capillary test. You're going to be doing potassium regularly via VBG. Neurological examination, we'll talk about why, and obviously fluid balance. Here is the guideline, and it's changed a bit since I was at med school. So I actually had to take a couple minutes to look over it, right? So here's how you're going to diagnose it. I think it's a really nice way to look at it. You've got clinical history, clinical signs, and biochemistry. So you've got 3 arms of how you're going to diagnose DKA. So you're going to have the symptoms coming in, you're going to have the signs on examination, and you're going to do quick blood tests, if you can, to work out A, if it is DKA, and B, how bad the DKA is, okay? If someone is shocked, you go straight into fluid boluses and try and resuscitate them. Once you once they're conscious and they're blood pressure is stable and of a, a reasonable level, then you're going to look at their dehydration and try and start DKA therapy, not just resuscitation therapy. The level of dehydration is stratified by the pH. Okay, so when I was at med school, it was only 2 classes, mild and severe, or moderate and severe, and now it's mild, moderate, and severe, going by pH. So it's a bit trickier. All right, so the lower your pH, the more dehydrated you will be, and the more volume you have to replace over a 48-hour period. Okay, so that will be a percentage over of their body weight. Okay, so you're going to correct the deficit over 48 hours, like we said. You're going to give 1 fluid bolus of 10 milligrams per kilogram. You're going to use 0.9% sodium chloride with 20 millimoles of potassium, 40 millimoles per liter. Okay, it's written 20 per half, but I always like to think of it as a liter. And you'll start an insulin infusion. Usually it's 0.1 units per kilogram per hour, an hour after starting fluids. All right, so the insulin will lag behind the fluids for the reasons we've discussed already. Like I said, so the moderate one, I would kind of ignore it a bit because I think it will just complicate matters and make things a bit trickier to concentrate on. So here's the rest of it. So you're going to now do observations as we talked about, ketones, glucose, neurological examination. When the blood glucose falls below 14, this is the critical number, you start adding 5% dextrose to the sodium chloride. And you reduce the insulin infusion because you don't want to drop that glucose too quickly. Give someone a hypo, create more issues for yourself, all right? You need to make sure that you don't drop that glucose. Remember, the role of insulin is to drop the ketones and stop ketosis. As you can see, okay, you stop the insulin at the point, I mean, the chart is kind of messed up formatting-wise. I don't know what they've done with it. I'm sure they'll publish a better version soon. You stop it when the blood ketones are less than 1. That's when you stop insulin infusion in DKA, okay? So that's your end goal, not a certain blood glucose cutoff. It's at a ketone cutoff, which is something, I mean, I'm sure many of you will have known, but I'm not sure everyone will have known, and I'd like to just re-emphasize that. Neurological signs of deterioration. So if someone is hyperosmolar for a long period of time and you pump them full of fluids, their body will not adjust quickly. And what you'll get is cerebral edema. And cerebral edema can be life-threatening. It can be really, really, really bad. And that's why you give the fluids slow. And that's why you always do neuro-obs at regular intervals, sort of hourly intervals. And you want to exclude cerebral edema, okay? And if you do accidentally give someone cerebral edema, then the way to manage it is with hypotonic saline to increase the osmolality of your serum, or mannitol to reduce the ICP. But at that point, you made a bit of a mess of it, okay? But I've just left it there as a sidearm because that's what you want to avoid, and that should never be the case when you're managing DKA. I know it's really complicated. I'm sure there'll be some questions about it. But the whole, the arms of management here, I'll just go back, probably give you the best idea of what to do, right? So we'll just go over it again. Fluid boluses, maintenance fluids, plus a fluid deficit correction, right? Insulin infusion to lag everything with the aim of stopping ketosis. Add dextrose when the glucose reaches 14. Regular observations, glucose, ketones, potassium, and neurological status to make sure there's no cerebral edema. Those are probably the key takeaways from managing DKA. It's really complicated. Many trusts have 8-10-page documents where you fill in the child's weight and age, and you trace it through and you fill it in hourly to make sure you achieve the right outcome, because then people make a mess of it a lot. You're not going to be expected to know all of this in such detail. You need to understand the principles. You need to understand what every arm of treatment is achieving, why we're doing things that we're doing, and why we're not doing things that we're doing, why we're not filling them full of fluid, why we're not keeping max insulin running straight away, okay? Right, let's move on to, here we go. Oh, someone's messed up my animations here. Okay, never mind. Well, it was going to be a quick question, right? If you've got a child leaning with their hands outstretched against the table, drooling, they look unwell, okay, what do you think is going on? And the answer is epiglottitis or bacterial tracheitis. Bacterial tracheitis these days is more common. Epiglottitis is sort of a legacy question. It's a famous one that they like to make sure you know. It's caused by Haemophilus influenzae type B, but with the advent of the vaccination, it basically doesn't happen anymore. You don't see it. You see bacterial tracheitis way more often. What do you see on examination of the throat? Does anyone want to put it in chat? Yeah, nice. Okay, good, good. Steeple sign. Okay, and we do not look in. So the patient leaning against the table is known as tripod sign. Okay, but we do not examine the throat. Okay, because if you examine the throat in a child with a little tongue depressor, you can get, yes, so you get the anesthetist, you get ENT. If you examine the throat, okay, it's like you're walking up to a bomb, all right? You do not touch it. You walk away very slowly with your back against the wall and keep everyone happy, right? Because if you make the child agitated, they're already agitated. If you make them more anxious, the airway closes up more, they get a higher respiratory demand, it escalates very rapidly, and you can end up with an airway that is now not intubatable, because as it closes up, it becomes harder and harder to intubate, and things go south really quickly. So do not examine the throat, all right? Call ENT, call anesthetics, okay? The choking, do not attempt to remove the object, okay? Do you know why that is? Even if you can see the little piece of Lego just there, like, just the corner of it poking out. Do you reach in with your fingers, or if you're feeling fancy, get a pair of tweezers? Yeah, exactly. So if you push it further in, okay, you're in real trouble because not only has the patient deteriorated, you've actively caused harm, and that's bad. Okay, that's real bad. Okay, so you do not touch it. You're the F1 or the F2 or even the ST3. You don't touch it, because that can go south really, really quick, even if you can see it. And who do you call again? Anesthetics, ENT, your favorite people as a pediatrician. Now, here is a quick view on choking. So if you've got a patient choking on some food, you want to assess how bad they are. So you want to assess, are they cyanotic? Do they have respiratory exhaustion? Does their cough look effective? Okay. If they've got an ineffective cough, you open the airway, so you do your jaw thrust, and you position them properly, and you start CPR. You don't remove the object, okay? If they're conscious, you can do 5 back blows. Okay, so it's literally just a slap on the back. You just hold them forwards and you slap them on the back, depending on how old they are, all right? And you can do 5 abdominal thrusts. So that's like hold like a Heimlich, but with 2 hands, and you just grab them with your fingers, depending on the size of the baby, okay? So you're going to aim to open the airway. If they've got an effective cough, they're coughing, they're improving, they're putting good effort into it, you can feel like they're helping. You don't want to get involved in that. Okay, you want to make sure that if you can let them clear it themselves, you let them clear it themselves rather than getting involved, making them more anxious, making the situation worse for everyone. Okay, and if you start walking, they're trying to slap them on the back, maybe they stop coughing and then things get worse. So you want to assess how ill they are, cyanosis, respiratory effort, exhaustion, and then you want to assess the effectiveness of their cough, right? Those are the 2 key points when you are looking at airway management in a child. So I think this is the last one. Status epilepticus, defined, so it used to be defined when I was at med school as seizure for 30 minutes. So you sit there twiddling your thumbs for 30 minutes, it's status epilepticus, let's treat it. Now common sense has prevailed, thankfully. So now if it's 5 minutes and longer, or 2 or more seizures with a short interval period between them. In fact, people don't sit around waiting for 5 minutes. People just treat. Like, why would you not just treat someone with a seizure, right? The thing is, by the time you try and get IV access and manage them and settle the airway, it can take a few minutes in and of itself. Causes, meningoencephalitis, super vital to rule out in a child. Intracranial, so malformations, AV malformations, hypoxic ischemic encephalopathy, HIE, space-occupying lesions, so malignancies and cysts, vascular causes, okay, aneurysms and so on, neurocutaneous syndrome, so things like tuberous sclerosis, neurofibromatosis, electrolyte abnormalities, so low glucose, magnesium, calcium, sodium, just irregular stuff really, and epilepsy, of course, the final cause, where essentially no one knows there's any primary cause to deal with. So you need to do a rough A to E assessment. I've broken it down to the key points here. To remove anything from the, anything around the patient, or remove the patient from anything that could cause them harm. If they're on the edge of a bed, there's surgical equipment nearby, airway equipment. Like, you don't know what happens when a patient's seizing, so you need to make sure there's nothing around that can cause them to choke. They've got an oxygen mask on and it slips and it starts choking them, for example, or something. You need to make sure there's no harm to the patient. Aside from that, you need to make sure the airway remains patent, and you give them on high flow oxygen, just because you give everyone high flow oxygen. You're trying to get IV access because IV management of seizure is much more effective than the other sources, the other forms of management. Again, don't forget glucose. Don't ever forget glucose. Okay, so the glucose, again, you can do a quick cap glucose or a quick ABG and go and check all these things. You're going to take bloods. You're going to do full blood count. You can do U's and E's, magnesium, calcium, and you're going to have a look for any causes. And you're going to take blood cultures. If someone's febrile and you suspect meningoencephalitis, you're going to do that. Okay, you check the pupils, or for a neurodeficit if you can. You're going to look for a rash. Okay, because you're going to look for, again, signs of meningoencephalitis. And you're going to try and maintain normothermia of the patient, because these patients can seize because they get cold or hot, and can become cold or hot because of the seizure. So it works both ways. If you are a show-off and you're trying to look good in your Viva, you can consider mannitol or hypertonic saline. If you've got signs of raised ICP, or you know a patient has raised ICP and they start seizing, you can consider that. If you're one of those who likes to be special. Here's the protocol. It hasn't changed much in all this time. It's very straightforward. You're going to try and get IV access. That's the cruxes. Okay, so you get IV access, you're going to try and give IV lorazepam or IO intra. Sorry, I've just had a complete brain fade. In the bone, IO access. You're going to try and get IV or IO access, and you are going to give them 2 doses of lorazepam 10 minutes apart. Don't worry about the doses. It's dependent on their weight as compared to adults, where I think it's a set dose. If you don't have vascular access, you can give buccal midazolam or rectal diazepam. Buccal midazolam not used much, because if someone is seizing, they have an airway risk, and you can risk, causing them to aspirate, which is a whole nother world of problems. Rectal diazepam, very simple, very easy. In fact, it's given to patients' parents. If the kid starts seizing, to just pop this in at home. I know it sounds crude, but it actually is very, very effective. You basically buying yourself time with the buccal and rectal substitutes to try and get 10 minutes to get IO or IV access. Intraosseous access is IO. I completely blanked for a minute there. Again, you're going to wait, give it time to work. Okay, maybe do your investigations in the time period between them. After 2 failed benzodiazepine doses, now you really need help. So you should have called for help before, right? You should have called for help. Probably after 1 dose, you go and call for help because you've got a little break time. Okay, now is the time when you sit back and let the big boys wade in. Your anesthetist comes in. You're going to start, phenytoin. You're going to do paraldehyde. You're going to consider rapid sequence induction, and all that heavy stuff. Okay, and now that's a very severe resistant seizure, and these patients are going to need intubation and ITU care after they've finished seizing, most likely. All right. The key points for you guys: maintain the airway, remove risk. If you have IV access, 2 doses of lorazepam 10 minutes apart. If you don't have IV access, buy yourself time with some rectal diazepam and try and get IV or IO access in that 10-minute time. And call an anesthetist after your first dose, because you're going to need them one way or another. It's always best to be on the safe side. Okay. So I've kind of rushed through a few big topics. They are big topics. I do appreciate that. I've tried to give you all the important information to hang on to without too much fluff, even though I know I can go on a little bit sometimes. I want you to come away with this from this hour, and if you ask some questions, please go on the Mentimeter now and ask questions away, or ask them in the chat, and I'll try and address them all. Have a few key signs of an unwell child in your mind. I want you to be able to picture a green baby, a yellow baby, and a red baby by the traffic light system, so that when it comes to an SBA, you can do it. Because in an adult, the blood tests and the clinical observations tell you a lot more than in a child. In a child, your endobetogram is far more important. Does the child look well is one of the most important questions, which in adults, very rarely do you say they look well. I mean, you do, but it's not as important as, the white cell count or CT scan findings and things you're not going to be doing in children. So most arrests in children are respiratory causes, and the management of an arrest is reflective of this, okay? You're going to be giving more respiratory care. So the inflation breaths and the rate of the rate of ventilation breaths to compressions is different. Okay, so just bear those 2 in mind if you remember nothing else. Fluid management. So in your mind, it's very complicated. I do appreciate that, but try and understand the bolus. So we talked about the bolus is 20 mils per kilogram most of the time, and you give 2 of them. And then maintenance fluids stratified by weight. I've sort of broken it down on the earlier slide. If you want to go back and have a look, it's widely available online. and just do a few calculations. Just pick a weight of child. You can start from the babies, and you can work your way all the way up to the, the guys who are, with acromegaly, and you can work out what fluid balance they're going to need over 24 hours and until you get really comfortable with it. Anaphylaxis, it's important you pick up the signs quickly, okay? The management of anaphylaxis, the adrenaline has low risk. People shy away from IM adrenaline is remarkably safe, all right? It does not cause many long-lasting side effects, okay? At worst, you will cause someone's blood pressure to be a bit higher or their heart rate to be a bit higher. It's nothing that will kill them. The anaphylaxis, however, will kill them. So it's a very quick response needed, okay? And I like to include that with the DKA because they're quite different. They can both kill you, but anaphylaxis kills you a lot quicker. And DKA needs time, and you need to consider a number of factors in managing a DKA patient compared to an anaphylaxis patient. All right, so they're both emergencies, but they're very, very different types of emergencies. The other thing is guidelines are going to change. So when you're at med school and you're learning them all, as I did, and I kind of love them a bit because they kind of work for me, learning a flow chart with colors and bold text and all that good stuff. You come back and you have a look at trying to teach med students something, and you're like, oh, well, it's all changed. So what was the point, right? And this has been like a year, it's been 2 and a bit years since I did pediatrics. So yeah, after a few years, who knows how it'll have changed. So try and understand the principles and why things are managed in a certain way, so that when they do change, you're able to adapt rather than just having to remember a whole new set of calculations and parameters. All right. Fine, adult stuff finally still applies. You will have tension pneumothoraces, you will have SVT and VT. They do happen in children. You will have tamponade. Whoever asked me, still rare, but it probably has occurred, and I wouldn't want anyone to tell you that it doesn't. And Addisonian crisis, congenital adrenal hyperplasia. These things still occur in children, and just because I haven't covered it and it's not pediatric specific doesn't mean it doesn't happen all the same. Okay, and here finally is another chart from LaSalle, sort of expanded one from what I showed you, which I really like to help me understand when I'm looking at, a patient or considering an SBA, I kind of stratify by what kind of shock I'm looking at or what kind of emergency I'm looking at to work out what is wrong with the child. All right, and that'll be on the slides. You can have a look at that later.